It's an honor to be here, and I'm looking forward to a good discussion this evening. Um, uh, I'll start. So I just have a couple of disclosures. I have no financial disclosures, and then I have some funding from the NIH to study essentially the evidence-based adoption and diffusion of robotic surgery across the United States. My goals for the next little bit are essentially describe the current state of robotic surgery in the United States, discuss some of the evidence for and against using robotics and why there's some controversy still ongoing, and then some things that we're working on to try to create a little bit more of an evidence-based adoption of robotics within surgery. So one thing that we've noticed in the United States is that there is rapid adoption of robotics across many domains of clinical care. This is a study that was published in 2018, which basically shows that the United States is now performing more robotic surgery than every other country combined. Notably, on the second panel on the right here, what we find is that while urology and gynecology have been using robotics for a lot longer, the general surgery population is growing the most rapidly in our country. This is some data just from one state in Michigan. One of the reasons why this is important, though, is that this is clinical registry data that is manually abstracted from the electronic medical record. And so we essentially can ensure the accuracy of it. A lot of the data that we gain from or learn about the use of robotics is through claims data. And so there's some limitations around whether we know that the procedures were performed robotically or not. But what you can see is essentially a steady increase in the use of robotic surgery over time. And particularly in general surgery, again, this is the clinical domain where we see the largest uptake. We're seeing, between 2 and 40-fold increase in the use of robotics over just about a 6-year period. And I'd just like to draw your attention to inguinal and ventral hernia. This has now been corroborated in several other studies nationally where we're seeing massive increases in the use of robotics for simple hernia repairs. One of the common argument to support the use of robotic surgery is that it facilitates uptake of minimally invasive surgery, meaning it allows people who would otherwise be doing this operation in a standard open fashion to do something that may be safer, quicker recovery, and enable them to perform the same procedure in a minimally invasive way. This is national Medicare data from 2010 through 2016, and what you can see in this first panel is that as the use of robotics for colectomy increases over time, what we're actually seeing is a leveling out of open surgery, some decrease, but what we're seeing is a gradual decline in the use of laparoscopic surgery, suggesting that robotics is actually replacing laparoscopic cases, perhaps even more than it is open surgery. Now, what we did in this study was we looked at the hospitals that perform actually the most, so the highest users of robotic surgery. And what we find is that it's actually eclipsed laparoscopic surgery. And so, again, what we found here is nearly a 2-to-1 replacement of an already minimally invasive procedure compared to replacing open surgery. This is data from from the state of Michigan. This is about 80 hospitals in the state of Michigan. And what we see, this line in the middle is essentially the year that the hospital obtained a surgical robot. And what we see is that in the years leading up to that, there is a gradual increase in the use of laparoscopic surgery. Again, this is all general surgery procedures, hernia repairs, gallbladders, colectomies. And after the hospital adopts robotic surgery, obviously we see an increase in that, but we see a leveling out of and even a slight decline in the amount of laparoscopic surgery that they're performing. In the United States, we have this kind of multi-payer system where a lot of the Medicare and Medicaid or government-based payers pay at a less generous rate than private insurance. And so there's been this question along about whether private insurance is actually driving the uptake of robotic surgery. Again, we know that it is more expensive to provide this service at the hospital level. And so there's been this question about whether hospitals that have more private payer patients are doing more robotic surgery essentially because it makes better sense for their bottom line. This is again data using both a kind of working age private payer claims registry and then Medicare patients. What you can see is the Medicare patients are in this, kind of yellow orange color, and the privately insured patients are in black. And what we can see basically is that there is some slight, there really aren't any major differences in the uptake of robotics based on payer mix. So this isn't necessarily something that's being driven by potentially more generous reimbursement from private insurers compared to Medicare or Medicaid. One thing that we look at or think about when we see something, sort of a very rapid change in clinical practices, are there any early warning signs about something that may not be right, whether this is a safety issue, a cost issue? The United States Food and Drug Administration a few years ago issued this warning against the use of robotic surgery for mastectomy, but then in that communication, they also voiced some concern over the use of robotics for certain gynecologic procedures. And it was sort of an interesting moment because the FDA does not generally come out quite this strongly against a new technology. And in fact, the data for mastectomy at that time, there was essentially no evidence for it, which is not necessarily that remarkable, but the fact that they came out so strongly would suggest that they either had some information or they felt very strongly about that this was a big issue. We wrote an editorial about this, basically suggesting that this was an opportunity for the government to facilitate the evidence-based diffusion of robotic surgery. And there are certain ways that they can do this, and I can talk a little bit more about that. But really kind of a call to gain more data, understand the gaps in our what information we have, and be a little bit smarter about how we leverage data to explore the use of robotics across different clinical domains. The CMO of Intuitive Surgical, the company, wrote a reply to this and was actually very sort of spirited debate around this. And I think at least in the United States, this just highlights this tension between regulators and industry that, again, I think facilitates a lot of good in our system, but also facilitates a lot of questions about, who's driving the diffusion, and then how clinicians fit into this, I think, is an interesting question. One of the big issues, at least in the United States, is that we have lots of clinical trials, not lots, but some clinical trials suggesting that robotic surgery is no better or different than traditional laparoscopic surgery. But there's this very real and very reasonable argument that it doesn't reflect real world practice because these are clinical trial environments. They're very subspecialized patient populations, or these are only certain types of surgeons that have either done a lot of both types of operations. And so in different hands, they may have different results, and there may be efficacy for robotics that we're not necessarily unmasking in clinical trials. This is a study that looked at basically the comparative safety and some oncologic outcomes between laparoscopic and robotic resections for rectal cancer. And essentially what they found was that there were no significant differences in conversions to open procedures, positive margins from an oncologic perspective, and overall the complication rates were generally the same. But again, this was met with this question of, in different hands or in different circumstances, in quote, real world practice, we may see different things. We have sort of taken to addressing this gap in knowledge where we look at, okay, we have these small observational studies from single centers that may not be generalizable. We have these trials that we argue don't reflect real world practice. How do we come to meet in the middle and develop some sort of understanding and create better data? We use large national registries to study these questions, but one of the issues that comes up is selection bias. All of these things that are important we may not be measuring in the clinical data. And so we have taken to using some natural experiments specifically around how robotics diffuses across the country to limit some of these issues of selection bias when we compare robotics to laparoscopic surgery or open surgery. This is a map of different hospital referral regions. They're essentially markets around major referral centers in the United States. And what you can see is that patients, based on where they live, are more or less likely to receive a robotic surgery. And what we did was we used this randomness, this natural experiment to address some of the selection issues. Again, we're able to essentially pseudo-randomize patients based on where they live. And what this does is it allows us to control for things that we can measure, but also control for some things that we can't measure and get better answers. And so what we found first is that when you compare robotic surgery, this is for colorectal resections, When you compare robotic surgery to open surgery, we note that the overall complication rates are lower for robotics. But what we found is that surgical or technical complications, like leaks from the new connections that they make, bleeding, returns to the operating room, are actually higher for robotic surgery, meaning we would favor open surgery. When we compared robotic surgery to laparoscopic surgery, we didn't find any significant differences. And so this is a bit of a nuanced finding, but what it suggests is that the benefits of robotic surgery, at least compared to open, may be because it's a minimally invasive operation, not because it's a robotic one. There have been some trials. Again, I noted that hernia repair is this area where we're seeing a massive increase in the use of robotics. And there have been several trials. This first one was the Rival trial, which essentially compared laparoscopic and robotic inguinal hernia repair. And they found no clinical benefits, higher costage, which again, we know. And then they had an interesting outcome, which was surgeon frustration that they measured based on a survey instrument. And so they actually found that on a number of domains, robotic surgery was not necessarily superior to laparoscopic surgery. This was a similar trial, similar setup, but compared patients with ventral or incisional hernias. And they essentially found no differences in patient-reported outcomes, so their sense of how their recovery went, wound complications, which are a big deal for this type of surgery, and again noted higher costs for robotics compared to laparoscopic surgery. This was a study published in the New England Journal of Medicine, which compared open versus minimally invasive. Again, the minimally invasive group here is a combination of both laparoscopic and robotic resections for cervical cancer. And what they found was that at 3 years, there was worse survival in the group of women that had undergone minimally invasive surgery. The interesting finding here was that they compared that trial to observational data used during the same time through a national cancer registry in the United States. And they essentially found a similar finding. But in the observational study, what they did was they went one step further, and I'm just going to draw your attention here that the differences between laparoscopic and open surgery, there was essentially no differences in outcomes. And so this finding that where they had lower survival or worse survival in the minimally invasive surgery group is essentially being driven by patients having robotic resections. And so actually the gynecologic oncology community has really come out strongly and in some ways changed their practice against minimally invasive surgery for some of these operations. This is essentially saying the same thing, but if you look at the dots here, this is the adoption of minimally invasive hysterectomy for cervical cancer. And you can see that as more and more procedures are being done in a minimally invasive fashion, we actually found that the 4-year relative survival rate actually fell off trend and started to get worse, suggesting that this adoption of minimally invasive surgery, again, potentially driven by robotics, is actually resulting in worsening of outcomes, which is counterintuitive. So, where do we go from here? I think there's a lot of questions. There's definitely a lot of controversy and differing opinions in the United States. I think based on what evidence we have and what we've seen is that I think the enthusiasm for robotic surgery is definitely outpacing the evidence right now. I want to be clear that there are surely indications for robotics and surgery. I think we just haven't fine-tuned them enough. Obviously, with prostatectomy, this has sort of transformed how they care for men who have prostate cancer. Open prostatectomy is a significant morbid procedure, and the fact that most, at least in the United States now, are done robotically has definitely made it a safer operation. I think there are clear indications in colorectal surgery or in esophageal surgery. We just haven't fine-tuned that. I think the question, at least in the United States, that is unanswered right now is that the costs of this are higher. That it is likely that they may start to spill over to patients. Again, if hospitals are providing more and more robotic surgery at a cost to them, the question is whether this will drive up the overall cost of care. Patients, that we don't know. I'm going to show you a picture. I'm a transplant surgeon, so this is just something I wanted to show you. The idea here, basically, this is a kidney transplant being done robotically, and it's fun to watch because it's pretty cool. But I think the point to be made here is that the limitations of our imagination or our ability to do these things are are not a significant barrier to exploring the use of robotics in other domains, but that doesn't necessarily mean that is the right thing to do. I have no agenda here about robotic kidney transplant. My point is basically just that we're rapidly diffusing a technology across multiple clinical domains. Now it's the same technology, we're just applying it to the same clinical problems. And so I think a couple things that we've sort of taken away and our research group focuses on is that when you think about how robotics should be used, there should be very specific definitions about the problems, the clinical problems, the technical problems in the operating room, and how robotics can fix them. All forms of evidence are important, from observational studies at centers pushing the envelope, doing things like robotic kidney transplantation, to clinical trials, to these large-scale registry studies across an entire population to look at how robotics is performing in two different groups in two ways: diverse groups of patients, and then also diverse groups of providers, so surgeons that may be better or worse at applying that new technology to the clinical care that they provide. One thing that governments can help facilitate is registry creation, so the collection of data at a large scale to help us determine that. And clinical societies like Choosing Wisely or certain clinical societies elsewhere can assist in that, in essentially helping to bridge that gap and understand what type of information we need to collect, how we can collect it, and what would be most valuable to patients. I think at least in the United States, I noted this tension between industry and regulation. And I think there's always been this reluctance to partner and collaborate. And I think that the more collaboration that we can have between industry and government and clinicians, I think the better we'll be at coming to middle ground on some of these issues. And the last thing I would say is that clinicians are really going to have to lead in this issue because everyone else has their own priorities and agendas. And I think, what you guys are doing with Choosing Wisely and what other societies around the world are doing to try to bring evidence-based care really should be driving a lot of this. And again, just thank you so much for your time, and I'm happy to answer questions and look forward to talking more in a little bit.